clients' voices in our work, an ethics sampler. So we're going to give you kind of bite-sized information about these topics. I am Dr. Sarah Mead Jasperse, and I will be chairing the session today. I'm an assistant professor at Emirates College for Advanced Education in Abu Dhabi. So we are hosting the event, and this event is part of a grant that is funded by the Abu Dhabi Early Childhood Authority. So we want to thank both of those entities for supporting our work. Today, I will just be kind of orienting us to what we're going to talk about, but the real content comes from our 4 expert global advisors. So we're going to have Dr. Cody Morris talking about toward a further understanding of Assent, Dr. Alice Shillingsburg talking about the role of therapeutic rapport in gaining assent to ABA therapy, Dr. Jennifer Austin talking about trauma-informed care, basics for behavior analysts, and Dr. Fahmie, safety and validity of analyses of severe problem behavior. Like I said, these are amazing researchers who have done a lot of work in this area, and I've only given them 25 minutes to talk about it. So they're going to be giving you just a sample, introducing you to their work, and then hopefully piquing your interest to explore more. A couple of logistics for today. We are using the WebEx platform. You will notice all of you were muted automatically. When you join as an attendee, you are already muted. If you would like to communicate with everyone, though, we usually have a very active chat during our sessions. You go to the chat and you select everyone, and that sends a message to everyone who's here in the audience today. So feel free to chat throughout. Do note the presenters won't be able probably to see your chat during their session, but we'll try to answer some of the questions in the chat maybe at the end. If you are here because you are interested, you're a behavior analyst and you are certified by the Behavior Analyst Certification Board or by QABA, and you are here because you are earning continuing education credits for either of those 2 entities, please take note of, we're going to have 2 code words. Please write those down on your own piece of paper, jot them down, remember them. Don't put them in the chat. Remember them for yourself, because in order to get your continuing education credits at the end of this session, you're going to need to complete a CEU form where you'll put those code words in and an evaluation survey at the end. Our system is automated, so you'll complete the form, submit it, and then you'll get your CEU certificate automatically. Now, because we offer you your CEUs for free, we also use a platform that makes our certificates for free. So we'll limit. It's about 60 per day. So if you try, that means that someone else had faster fingers than you today. You just need to remember those code words, and then tomorrow you can try again and plug them in. Depending on how large our audience gets, if you try today, you try tomorrow, and you're receiving an error, please try the day after. Again, it's because we will have hit our quota for the day. That are the majority of the logistics. If you have other logistical questions, please ask in the chat. I will be monitoring that throughout. But let's move into what we're talking about. So we are all here today because I'm leading a team that has been funded by a 3-year research grant from the Abu Dhabi Early Childhood Authority on the topic of amplifying children's voices in early childhood development research. This grant was granted to the Emirates College for Advanced Education in partnership with the Mohammed bin Rashid Center for Special Education, operated by the Newland Center for Children, both of these entities in Abu Dhabi. So this is our research team. I have 2 co-principal investigators, Dr. Michelle Kelly and Dr. Shannon Ward, who are working on this project with me. Dr. Javier Varela-Ortega is our research director. We have 2 fantastic research associates, Shaza Atia and Victoria Nguyen, and an incredible research executive assistant who holds us together, Reem. We're going to be talking about some terms today, and our global advisors are going to help with some of the terminology. But I just want to be clear with some terms that we're going to use. So you may be familiar, may not. We're going to be talking about consent a little bit. And consent is a formal agreement with legal implications to participate in an activity. So usually for young children, parents are providing consent for their children's participation. So there are many activities that need consent: medical procedures, educational assessments, research activities, sports and leisure. You're going to go to a camp, you need to sign the consent form. So when parents sign a permission form for an activity, they're giving consent for their child to participate. What we are more interested in here is assent. That is a proxy to consent for those who cannot legally consent. For example, those under the age of 18. In our grant, we're especially interested in those under the age of 9. Some people of determination as well, so you'll hear different types of groups that may fall into the assent category. You'll hear different definitions today as well, but generally an affirmative response, an agreement, that's taken to indicate a willingness to participate in an activity. So when a doctor asks a child if they can take a blood sample, that doctor is asking for assent. The parent gave consent. They said, yes, you can take the blood sample from my child. I signed the form. When they turn and ask the child, that then is assent. Why is assent important? A lot of reasons, but a core one is just human rights for children. So if you have not taken a look at the Convention on the Rights of the Child, I would encourage you to. You could follow the QR code here. And this is really where a lot of our work is anchored. So a lot of the big ideas come back to this convention. So we started asking some questions about assent. We wanted to follow a couple of paths. We wanted to have a knowledge gathering path, figure out what people are doing about assent, as well as have a knowledge generating path. We are conducting some experiments to figure out what are the best ways to seek assent. So this is a 3-year project with many studies that we're conducting, but we're very excited to, at the end of our first year, have invited 4 expert global advisors who all bring unique areas of expertise to this topic. So we have Dr. Cody Morris, Professor Alice Shillingsburg, Professor Jennifer Austin, and Dr. Tara Fahmie physically here with us in Abu Dhabi, and they have all agreed to share some of their expertise and knowledge with you as well. So they're each going to have 25 minutes to kind of share their area with you. I'm sure there'll be lots of questions for them at the end. So I am going to stop sharing my screen. Dr. Cody is going to be up first. So we'll go one by one. Dr. Cody's coming on. See, I didn't even know you could do that, Dr. Lena. I saw Dr. Lena clapping for Dr. Cody coming on. All right. So Dr. Cody is going to take over. So it is 3:07. So he's going to have 25 minutes, and then we'll move on to the next talk. You ready, Dr. Cody?
I am.
All right, it's all yours.
Hi, everyone. Thank you for coming to the talk today. I'm really excited to be here in Abu Dhabi to get to speak with you all about a topic I'm very passionate about. Before I jump into it, I just want to say thank you to Dr. Sarah and Michelle and everyone else that's putting this event on. Thank you to the Emirates College for Advanced Education for hosting us. And thank you to the Abu Dhabi Early Childhood Authority for funding this. This has been a tremendous experience, and I'm really glad to see different groups of researchers and stakeholders interested in this topic. As Dr. Sarah said, I'm Cody Morris. I'm an assistant professor and program director at Salve Regina University in Newport, Rhode Island in the United States. And in addition to being a professor and program director, I'm a researcher interested in improving behavior analytic practices, and one of those practices is Assent. And I became interested in Assent when I was in graduate school. Early in my training in my master's program, I was tasked with consulting in group homes for adults with developmental disabilities and severe mental illnesses, and children at home that had challenging behaviors. And early in my training, I was assigned a new client who was an adult with developmental disabilities and asked to go out to the home. I don't think I had met the client, or maybe I had just met them one time or so, and asked to go out to the home and attend a treatment plan meeting. And so I go out to the home, and there's a social worker there. There's a court-appointed guardian because the client was not their own guardian, even though they were an adult. There was a group home manager, day program manager, etc. And as we sat down to start the meeting, the social worker pulled out a sort of a thick treatment plan, like 30, 40 page treatment plan. flipped it to the last page where there's sort of a line for signatures, handed it over to the court-appointed guardian who signed it. There was really no discussion. They simply signed it. And then they put the packet in front of the client who just kind of looked at it. They don't believe that they had the ability to read or anything like that. And the social worker then just kind of pointed to the line where the client should be signing and gave the client a pen, and the client just kind of scribbled near the line. And they said, okay, perfect, right? We got consent from the court-appointed guardian, and now we have assent from the adult that had the court-appointed guardian. And, everyone was kind of, okay, we're all set today. And we adjourned the meeting. I don't know that it lasted more than 10 minutes of that. We really didn't talk about the treatment. We really didn't inform the client of the treatment. And I sat there aghast. I was surprised. I was shocked by what had transpired. And I started thinking that there has to be a more effective way of going about this, whether it be for adults that are not their own guardian or children who are obviously not their own guardian as well. There has to be a better way of getting them involved with the treatment planning process and getting them involved in making therapeutic decisions. And so I spoke to my graduate program mentor, Stephanie Peterson, and a colleague, Jesse Dietrich, about this, and we started working on various projects related to the topic. And then one of those projects developed into this paper that we published a couple of years ago on the topic of assent. And since that paper's been published, I've gotten to consult with people across the world to present on the topic and to hear sort of people's questions, interest, sticking points related to assent. And that has developed into more projects and more opportunities. And a lot of that I'll be sharing today, some of the insights I've gained through that process. And so what I'm hoping to do today is to provide an overview of assent and assent practices, provide a working definition of assent and related conceptualization, and then provide preliminary practical considerations for a client assent. Now, as Dr. Sarah pointed out, this is a very brief presentation. So this is a sampler. I'm kind of going to point to certain ideas. If you're interested in learning more about them, maybe we can chat in the chat after I finish presenting, or you can always email me as well. I'd like to begin in my sort of comments on assent by reflecting on the historical importance of client involvement in treatment planning and behavior analysis. We have a very, very rich history in our field of taking this sort of client-centered approach to treatment. And just to sort of name a few of the historic contributions in this area, starting with Skinner in 1959, talked about concerns around power differentials for the treatment of children with developmental disabilities and how it can impact the ability for children to exude counter control, or the ability to more or less advocate or push back on the system that was in control of their therapy and their overall environment, and sort of pointed out that children with developmental disabilities have a power differential with their caregivers that can create some problematic dynamics if not controlled for or addressed. Beowulf and Risley, when they wrote the 7 Dimensions of Applied Behavior Analysis, I highlighted the importance of social significance in treatment and in research, really highlighting the importance of whatever it is that we're doing as behavior analysts, having a positive impact on the client through the perspective of that client. Wolf wrote a paper focused on an evaluation of social validity, so beginning to come up with formal assessments to begin to look at this idea of social validity, social significance. Schwartz and Bayard followed that paper up and elaborated on it further, talked about social validity specifically in practice. And then Bannerman and colleagues wrote a paper focused on understanding the importance of sort of clients' rights as it pertains to being involved with clinical decisions and making sure that we're taking the perspective of having clients directly involved with treatment decisions and grappling with some of the complexities in that process. And these are just a few of the examples. There are several other examples that are really important to understand and reflect on in our field, and to recognize that we really have this history leading into some of this more recent work. And some of that more recent work within the idea of this client-centered approach to treatment or the involvement of clients in therapeutic decisions is the topic of Assent specifically. So there's been some recent work on that. Our most recent ethics code has talked about Assent directly. Myself and colleagues have published a paper a few years ago on the topic that I referred to. Flowers and Dawes and Bro and Smith both looked at research related to the professional requirements of Assent and some definitions of Assent. And then Dr. Sarah, who introduced the talk today, and colleagues published a paper surveying behavior analyst perceptions and practices related to Assent. And so we're starting to get some resources and some information specifically on the topic of Assent, which is exciting. Dr. Sarah had mentioned some of the reasons why Assent is so important. Well, it gives the client the opportunity to exhibit and practice self-determination and personal choice, which is an important piece when thinking about helping our clients prepare for the most independent and autonomous life that they can achieve. It provides clinically relevant information to the behavior analyst. It gives us information about what our clients are interested in, what they're willing to do, what they don't want to do, right? That's very valuable information for us. And it's also a component of involving clients in therapeutic decisions and client-centered services. It's one component of it. It's not the only component by any stretch of the imagination, but it is a very important piece of that. And so, given this importance of Assent, given sort of the renewed focus and sort of the specialized focus that we're starting to see in behavior analysis on the topic, I want to start by defining Assent. Dr. Sarah had mentioned sort of a brief definition or orientation to the term, but to go a little bit further into detail. So Dr. Sarah had compared consent and assent, which I think is very important when beginning to think about Assent. Most people are relatively familiar with consent. So consent being the affirmation that an individual who has legal authorization giving permission for themselves or potentially another individual to participate in a procedure after receiving adequate information, whereas assent is the affirmation of a person who doesn't have that legal authorization to provide consent for themselves, indicates a willingness for themselves to participate in the research after they've received that adequate information. And so there's a few critical pieces of this definition that I kind of want to break out and elaborate on a little bit. So the working definition of assent that I'm currently using as a client who cannot legally provide consent for themselves, as we talked about, that might be that they're a child, it might be that they're a conserved adult who's not their own guardian, indicates their willingness to participate in a procedure via a choice arrangement, so they're given the choice to participate or not, after they've received adequate information about the procedure, which we'll unpack in a little bit as we get into more detail on this, but there has to be an understanding of the procedures that they're going to be participating in, with the expectation that they can withdraw their assent at any time during the procedure. So if a client agrees to participate in a procedure, that doesn't lock them into that procedure indefinitely. They always have the ability to withdraw the assent if we're following assent practices. There are several considerations and nuances to arranging assent assessment or setting up our clients to be able to engage and assent procedures. I'm going to talk about 6 of them, which again is going to be a very sort of general orientation to some of these ideas. I could easily speak for an hour or probably multiple hours on each of these individual topics. And so this is sort of just a little bit of an introduction to some of these ideas. So starting with determining the applicability of assent. So when we start to think about assent, regardless of the population you work with, unless you're only working with people who are their own guardians, if you're working with people who have guardians, one of the things you have to determine is whether assent is applicable to that individual person or not. And there's some complexities in unpacking that. If you turn to our ethics code, the Behavior Analyst Ethics Code, it will say that we need to seek assent when applicable and when relevant, which is helpful to an extent, but maybe not as specific or direct as sometimes we would like it to be. And so we begin to look at maybe other sort of guidelines as to what that might look like. So several guidelines that look at assent often refer to this idea of the client or the participant being capable of providing assent, which is maybe a problematic term for several reasons, but it generally limits the people who would traditionally be given the opportunity to assent to individuals who have pretty robust communication abilities. So, for example, if you look at the common rule, which is the rules for human subjects research in the United States that all IRBs in the United States have to follow, it'll talk about the capability criteria as being someone who it can be reasonably consulted, has a certain maturity, doesn't have certain diagnoses. So it's quite limiting. And the reality is that most behavior analysts are going to be working with clients who would traditionally not be seen as quote unquote capable through some of these guidelines, which is very, very limiting. The other consideration with determining the applicability of assent is that assent has to predict the ability or the promise to produce therapeutic benefits. As I talked about before, there's some research showing that client preference for treatment options might predict effectiveness of treatment options, and so there's some interest there. But there's also been some research to actually show the opposite. So sometimes there can be clients who have a preference for treatment options that are the least effective option available or that have been assessed. And so oftentimes behavior analysts, if we're looking at trying to get clients involved with therapeutic decisions and getting their assent on components of treatment plans, have to grapple with the client might want to do something that's actually less effective than treatment or procedures that are currently available. And which one we prioritize is going to depend on several factors. The other piece that we have to grapple with is that some procedures might be necessary. There may be situations in which we really can't honor a client's decision or input on a given procedure. For example, I've worked with individuals who have to take seizure medication because they're at risk of dying if they have a seizure. So these are life-sustaining drugs that they need to be taking. And everyone on the treatment team, their doctors, their parents, everyone's going, yeah, there's like, they have to take the medication. And so the client might go, yeah, I don't want to take the drugs, I don't want to take the pills, and whatever way they demonstrate that, it may not be optional. They might need to take those pills. And so in those situations, we have to grapple with, okay, if the client has to engage in certain procedures, do I still arrange assent or still ask for their opinion or their choice of whether they engage in the procedure or not? That's complicated, and there's sort of conflicting recommendations on that. The American Academy of Pediatrics would say no. In fact, you shouldn't be asking clients if they want to engage in a procedure if they have to engage in that procedure. And instead, you should be providing them information about that procedure, explaining the importance of it, why they need to do it, and ultimately apologizing for not being able to provide them the choice. And so these are some of the kind of stickier points around grappling with that particular issue. Another topic is
Cody,
assessing.
I'm just popping in to give you a time check as the chair, so you have about 8 minutes left.
Yep, I've got it. Thank you. So the next piece is assessing Assent-related skills. So understanding the skills that might be necessary to assess Assent or to involve Assent in treatment or research procedures. When I've presented on the topic of Assent before, several people come up to me afterward going, I work with people who are nonverbal, non-vocal, so this doesn't matter to me. Well, again, that might be overly limiting, and there might be opportunities to arrange Assent for people who have limited communication abilities. Some of the complexities in this topic would be that we, as behavior analysts, work with clients with very diverse repertoires, and it's, I think, an amazing opportunity and an amazing privilege to get to work with people with such diverse skills and repertoires and interests and things like that. It's an amazing responsibility that we get to work with these types of individuals, but it can be complicated when figuring out how do we set up these sort of standard practices related to Assent or anything else. We also have to think about how we might assess specific skills related to Assent and where there may be skill deficits related to some of these critical features or critical components of Assent, how we might train specific skills related to Assent, because if our client doesn't have the skills related to Assent, it doesn't mean I should just go, oh yeah, they don't have the skills, moving on, and we're just going to kind of force them through procedures for the rest of their lives. That doesn't really make sense. And if the goal of behavior analytic services try to help increase independence and autonomy, then we need to, work on these skills that are going to lead to some of that. And then, I need to be thinking about efficiency and least intrusive approaches when I'm setting these procedures up. There are different ways I can arrange Assent depending on someone's skill set, and need to prioritize the strategies that might be, again, efficient and least intrusive. The next category is arranging Assent procedures. So how do you set these up? Traditionally, in practices beyond behavior analysis and even within behavior analysis, the standard Assent procedure is essentially like ask the client, speak the instructions to the client and ask if they want to participate in them. But you obviously have to have relatively robust communicative repertoires to benefit for something like that. And so the American Academy on Pediatrics has these sort of guidelines for what are essential for Assent, and then myself and colleagues translated some of those components into these 4 critical pieces. And so when I look at Assent, I'm looking for these 4 critical pieces being present and figuring out different ways of arranging these 4 pieces. So that'd be acquainting the client with relevant treatment options, making sure they understand what their options are, setting up discriminative stimuli for those treatment options, so ways that they can indicate which ones they're interested in, test and confirm the stimulus control for those components, and then ultimately arrange the choice. Another piece we have to think about is how to arrange a fair choice. So this is a tricky topic, I think, for behavior analysts. Oftentimes we want to make sure that we're not providing undue influence over the choice to participate in a procedure or not. But as a radical behavior analyst, I don't believe in free choice. I believe that there's always influence over behavior. And we have to then go, okay, well then how, if I know that there's an influence over behavior, how do I grapple with the issue of the client being influenced, by the procedures, by the context, etc. And so instead of striving for like a quote unquote free choice, I advocate that we look to arrange what I'm calling like a fair choice, and that would include looking at sort of the social validity of the choices, what stakeholders have to say about choices, what the community has to say about the choices. But rather than trying to set up these sort of non-influence choices that I don't believe exist, figuring out how we protect clients from undue influence and certainly coercion without having to strive for this completely free choice. The next topic is selecting opportunities to assess Assent. And so thinking about how we might embed Assent assessment into the client's procedures, how often we're supposed to do that, etc. So, the scope and the purpose of therapeutic services can greatly vary across practice and research. How you might set up Assent for individuals when you're working for a severe challenging behavior versus a school versus an early intervention clinic, there's going to be different amounts of opportunities, what those opportunities look like, etc. We have to be mindful of providing too much choice. There's actually this research looking at choice paradox. The more choice you provide, the least choice people engage in. And we also have to look at the fact that Assent is dynamic and is potentially changing. People's decision to participate or not participate can change from day to day, trial to trial, even moment to moment, and we have to have procedures that can grasp that. And the final part is informally assessing Assent. And so a lot of what we've talked about so far is this sort of formal assessment process, but there might be ways of informally assessing Assent. And I compare this to looking at the difference between a reinforcer assessment and a preference assessment. Reinforcer assessments directly assess the reinforcing effect of a stimulus. Preference assessments look at other ways of identifying potential reinforcing value of a stimulus. And so there's a few things we can look at related to that. Looking at Assent withdrawals being a major component of that. The trick with Assent withdrawals, you can't rely on it because the absence of Assent withdrawal cannot be a confirmation that Assent is ongoing for several reasons, because there's a lot of reasons that someone might sort of blindly comply with certain procedures and just continue participating in them despite not wanting to participate in them. And then other Assent related behaviors that I call Assent adjacent behaviors. So things like indices of happiness, things like engagement in the procedures aren't necessarily directly indicating Assent. They're potentially related to it and they're potentially very valuable in their own right, but they're not exactly the same thing. And so maybe including those in this informal assessment, but not mistaking them as Assent themselves. And again, all these topics are incredibly important, very interesting, and I wish I could go on about them, but ultimately what I'm hoping people get away from this talk is that Assent is one component of involving clients in therapeutic decisions and client-centered services, that it's multifaceted and it's nuanced, right? That we should embed it, that we should strive to use Assent and arrange Assent for our clients as much as possible, but understand that there are some complications related to it and work on that. And there are several critical pieces when we're doing that, and that much more research is needed on the topic. If you're interested in hearing more about some of those topics or interested in having any conversations with me about Assent, you can reach me at this email. Thank you.
Wow, absolutely outstanding, Dr. Cody.
Okay, hi. Let's see if I can do this as seamlessly as Dr. Morris did.
Doing great.
Let's see here. How does that look?
Right. Let's see. Give it a second. We have the full screen. It's your slides, and you're starting at 3:35. So we'll wrap up yours about 4 o'clock.
Okay, wonderful.
Perfect.
Well, this is really exciting to be here. My name is Alice Shillingsburg, and I am a professor at the University of Nebraska Medical Center at the Monroe Meyer Institute. I'm thrilled to be here. I'm going to kind of move into the topic of the role of therapeutic rapport in gaining assent to ABA therapy. And I love how our last talk sort of ended with talking about assent adjacent behaviors, because I think a lot of what I'll sort of talk about today, I think will sound a bit like assent adjacent behaviors. I also would like to thank the ECAE and the Abu Dhabi Early Childhood Authority for making this event possible. I'm just thrilled to be here. Okay, let's see if I can. Okay, so according to the World Health Organization, 1 in 8 people in the world live with a mental health condition, and many will seek treatment from a mental health provider. Now, for people seeking therapy, therapeutic rapport between the therapist and the client has long been recognized as a critical element in the success of behavioral health interventions. And one reason suggested for this is that positive therapeutic rapport helps build what is called the therapeutic alliance. Therapeutic alliance generally consists of the relationship between the therapist and the client and the mutual agreement between the therapist and the client on the goals of therapy and the specific therapeutic tasks that are going to be undertaken as part of the client's treatment. And several studies and meta-analyses have found that the therapeutic alliance is really a strong predictor of positive outcomes of behavioral health treatments. And this holds true across patient types, therapeutic modality, the presenting concerns, the treatment duration, and also the type of outcome measures that have been used. And a focus on a strong therapeutic alliance aligns with what many of us might refer to as a patient-centered approach. Now, this approach entails things like discussions with the patient about their hopes and goals of therapy, the patient and the therapist co-constructing together the treatment plan, including what specific tasks and activities are going to be involved. And 2 additional elements that facilitate a strong, building a strong therapeutic alliance is establishing positive interactions early in the therapeutic relationship, and then regularly revisiting satisfaction with the therapeutic process, which may again then result in perhaps making changes in therapy. Now, one reason early positive interactions and regularly checking in on satisfaction with therapy is so important is that therapy typically entails hard work. The road ahead or the sea ahead is often pretty rough. Most treatment-seeking individuals are going to address behavioral and emotional concerns that are difficult for them. And though they may, remain motivated to work toward their goals, they may make decisions to revise the treatment plan, change certain therapy tasks, maybe move more slowly through difficult steps, and so on. So building therapeutic rapport is a dynamic and bidirectional process that requires the clinician to be responsive to the patient and their needs. I love this quote where we think about this as it requires regular attention to the therapist and the client's mutual engagement in the work of therapy, because it truly can be work. Now, people with neurodevelopmental disorders such as autism are counted among those with mental or behavioral health conditions. But when we think about how to establish a therapeutic alliance between a behavior analyst and a child with autism, some complicating factors may come to mind. For example, children with autism often have co-occurring difficulties in language and communication. In fact, approximately 30% of autistic children do not use spoken language. And the children we serve also exhibit challenging behaviors, such as aggression, destructive behaviors. Now, taken together, it may be hard to consider how you might come to a mutual agreement on the goals and tasks of therapy, especially when the goals and tasks of therapy are difficult and require persistent practice for the child to learn new skills. For many autistic children, intensive behavioral interventions are needed. And by intensive, I mean 25 or more hours per week, sometimes for several years. And much of this time in therapy is spent working on skills which can be difficult to acquire, but are really critical for social and daily functioning. In fact, some of these skills are so difficult that our intensive intervention sessions can become aversive, resulting in avoidant and escape-related behaviors, maybe tantrums, aggression, elopement, or running off. or general sort of non-compliance or non-participation in your sessions. Now, effective evidence-based interventions to reduce problematic behaviors during instruction have been identified. These may include the use of escape extinction, differential reinforcement of alternative behaviors such as compliance or requesting a break from instruction. And use of escape extinction and differential reinforcement often entail requiring the child to sit and comply with instruction while noncompliance and attempts to escape instruction are ignored or blocked. And many clinicians have been taught to work through any problem behavior that occurs. So these procedures and others, such as three-step guided compliance, the third step of which is to physically guide the child to comply with instruction, have been shown to be effective at eventually producing compliance. But even with successful use of these procedures, avoidant and resistant behaviors may actually persist, but they become more subtle. So it may entail slow or latency to respond to instructions, or maybe inattention or turning away from the instructor. And although compliance with tasks and intervention may be achieved, compliant responding is likely reinforced by breaks from demands and ultimately escape from the therapist. And given that we often have years of behavioral intervention ahead of us, motivation to escape the therapy session and to escape the therapist is somewhat problematic, and I would say somewhat opposite to building a therapeutic alliance. So how do we balance this idea that the therapeutic alliance is an important feature in intervention and the reality that the work of therapy often does ask people to do hard things, and particularly in a population that cannot yet communicate or has difficulty understanding the communication of others. So today I'd like to describe a process of building rapport with children with autism who also have complex communication needs. And I hope you'll see some similarities with the features of the therapeutic alliance. Specifically, the process involves establishing numerous positive interactions between the therapist and the child. It involves listening to client motivations and using the client's non-vocal behavioral indicators of agreement to participate in therapy activities, and then regularly reviewing satisfaction with this population, which might mean taking data on the child's approach and avoidant behaviors to the therapy setting and to the therapist. And then also using that data to make client-specific modifications to the therapy activities when needed to then regain agreement with the procedures that are being undertaken. So the procedures that I'll outline today are based on a set of guidelines for practitioners that we originally published in this paper, Rapport Building and Instructional Fading Prior to Discrete Trial Instruction, Moving from Child-Led Play to Intensive Teaching. Now, specifically, this intervention entails identifying and using preferred activities and items in play and other preferred routines, strategic and intentional use of these reinforcers to promote approach behaviors to access these activities with their therapist, creating numerous opportunities for communicative behaviors and other behavioral indicators for the therapist to be responsive to. And this includes behavioral indications that the child likes with the therapy activities, tasks, other things that we're doing, but also indications that the child doesn't want to participate in certain therapy activities. And then beginning to introduce new tasks slowly and systematically when the child's motivation is at its highest. This work is based on the 1998 manual published by Sundberg and Partington, in which they describe the importance of establishing rapport prior to beginning instruction with children with autism. And they describe a process of associating or pairing the instructor with strong positive reinforcers, with the ultimate goal of teaching the child to like being with the therapist before presenting other therapeutic tasks. And only when the child is readily approaching the therapist should instruction begin. Now, several other researchers and clinicians have emphasized pairing procedures and rapport building, but most of these writings are focused on what it is and why it might work. And there really weren't a lot of empirical studies showing the effects of pairing. So I set out to do that, and in 2014, we published the study looking just at the effects of pairing on approach and avoidant behavior in children with autism. Now, our first step was to identify highly preferred items and activities, which we know how to do very well in behavior analysis. Use those reinforcers to repeatedly and consistently pair the therapist with access to those items. And then keeping in mind the goal to sort of change the value of interacting with their therapist, and such that they're responding during the interactions occurs to continue that interaction rather than to avoid it. So in this study, we wanted to examine if pairing an instructor with strong positive reinforcers would affect approach behaviors toward that instructor in later instructional sessions, and compare that to the child's responding with a non-pairing therapist. So we had two research assistants, a pairing and a non-pairing instructor. Baseline consisted of typical discrete trial instruction. And then in the pairing phase, one of the instructors stopped all demands and essentially continuously offered access to reinforcers. After that phase, she returned to presenting regular discrete trial teaching, while the other instructor just presented discrete trial throughout the evaluation. Now, one important factor to mention is that three-step guided compliance and other physical guidance was not implemented, as we were interested primarily in measuring the child's voluntary approach to the therapist and to instruction. We wanted to see the child choosing to stay with the therapist. Now, this graph shows the percentage of time the participant spent in his seat at the teaching table appropriately and voluntarily. The open data paths show the participant's behavior with the non-pairing instructor. The closed shows the participant's behavior with the instructor who would become the pairing therapist in the middle. Now, in baseline, the participants spent around 0 to 35% of their time in seat with both instructors, so not great. In the middle phase, you can see that one instructor stopped presenting demands and began pairing only. Again, no physical guidance was provided, and you can see within a few sessions the participant was voluntarily approaching and sitting at the table with the instructor, but we don't see that happen with the non-pairing instructor. Now, this is a great result, but potentially not that surprising. But it's here in the last phase when we see the pairing instructor resume discrete trial instruction, and there's this interesting effect. With the exception of the first session, the participant continues to come and voluntarily choose to be at the table with the instructor despite the instructions, but we don't see that effect with the other instructor. We also measured latency to sit with the instructor at the table. So how quickly upon seeing their therapist did the child approach and sit with the instructor on his own. Now, the data marker at the top, 600 seconds, indicates the child never came over and sat down and the session time elapsed. Now, you can see in baseline the participant sometimes came over quickly, sometimes didn't, no real differentiation with the two therapists. Once the pairing instructor began pairing and reduced instructions, pretty soon the participant began consistently and quickly approaching, and we see this persist throughout, but only with the instructor that took the time to pair. So our early results support the idea that spending time pairing the instructor with access to highly preferred items and activities can set a good foundation for ABA therapy, but we realize that the procedures described really just weren't enough to guide how to move from pairing to instruction. So we set out to do that and put together an intervention package, which I mentioned in this paper here. We first begin with pairing, as I just described, where no instructions are presented and the therapist spends the entire session pairing themselves with highly preferred items and activities. And in the beginning stage of the procedure, we're primarily monitoring approach to and avoidance of the therapist and the therapy setting as a key indicator of first steps toward rapport. Now, once we see the child begin to allocate their time in close proximity, preferring to be with the therapist, we move on. Now, our next steps are to identify and shape other behavioral indicators that mean they like what we're doing, and other behavioral indicators that might mean dissatisfaction with therapy. Now, for some autistic children with limited communication, this might look like reaching for things, pointing at things, maybe looking at things that they like, and indicators that they don't like what we're doing in therapy might be negative affect or pushing things away. And our first goal is actually to try to set up opportunities for these indicators to occur and then be responsive to them by providing more things that they indicate for and removing or stopping things that they resist. So we focus very heavily on reinforcing these indicators, which we call indicating responses, early in the pairing process before we start to work on other things. We want to identify and strengthen the existing ways of how a child tells us what he or she wants as we then move to progress to tackle more difficult things in therapy. Now, one of the first therapy tasks that we attempt is for the child to choose to come to the teaching session. And we do this simply by bringing all the preferred and engaging materials that we can to the teaching setting. When the child approaches the teaching setting or the therapy setting, we respond with access and play. However, it's this stage that access to the preferred items and engaging with their therapist starts to begin to require staying in proximity to the therapy space. Now, the child can decide to get up and go. They're certainly allowed to do that. We keep positive reinforcers at the table, and in this way, the child can more clearly understand their choices, that come over to the therapy setting, experience strong positive reinforcement, but get up, go, experience other options. And what we tend to see here is a lot of coming over, indicating for things, playing, getting up, exploring other options, and then coming back over. And over time, we see increased time allocation of their time spent in the therapy space with the therapist without having to use any physical guidance or escape extinction. Once we see the child approaching and remaining at the teaching table, continuing to indicate that this is a preferred context, they're engaging with their therapist, we enter the last phases of the protocol where we begin to teach. It's highly recommended that your first skills that you want to teach would be better mands, so starting to teach a communication repertoire, but we soon want to teach other types of skills, and what we recommend is instructional fading, which is a well-established practice used to keep instructional sessions from becoming aversive. Essentially, it entails slowly introducing instructions or therapy activities along a variety of dimensions. So slowly increasing task difficulty, increasing response effort, and the rate of trial. So in other words, you want to start with things that are easy, low effort, presenting things infrequently. And we try to present instructions when motivation is high, and of course we're constantly monitoring indicating responses to let us know when kids are continuing to be motivated to engage with us, or if that has changed. Now, the process of instructional fading leaves a lot to the clinician to decide. How do we monitor that the child is still agreeing to participate in therapy? So I'll walk you through a few guidelines. I call them guidelines because it's almost impossible to know the personal and nuanced ways that a child is going to respond during therapy. But generally, in the first stage of pairing, as I mentioned, preferred items and activities are offered continuously and non-contingently throughout the session. No instructions are presented. The child is not required or prompted to sit down. Nothing associated with the work of therapy, not yet. We're sort of following the child around, delivering fun activities, offering preferred items, and looking for indicating responses to reinforce. Now, we tend to look for a trend of behavior that lets us know that there's no avoidance of the activities. So potentially 3 sessions of low to no challenging behavior. And then we'll move on to stage 2, where we begin to start to look for now social approach behaviors to the therapist. It looks a lot like stage 1. There are no therapy task demands, for example, but we do begin to make engagement with preferred activities contingent upon spending more time in close proximity to the instructor. The child comes over, we present preferred activities in therapy, but they're still free to move about. And we look for, again, continued low levels of avoidant type behaviors, but now we look for spending more of their time, approximately 80% or more of their time, choosing to be in close proximity to the instructor. Stage 3 I call optional because it moves to having a child sit. I don't know that there's anything magic about having a child be seated, but depending on your learning context, you may want to do that. If that's the case, we would again continue to monitor any indicators of, wanting to avoid or to remove themselves from therapy, but and continuing to monitor what we're doing. Now, once we have a situation where the child isn't showing escape or avoidant-like behaviors, consistently coming over to the instructional setting without any physical guidance, we start to slowly present new therapy tasks, which of course are personalized to each client's plan. In stage 4, we begin by presenting one demand approximately every minute. Again, these are just guidelines, but we look for indicating responses to indicate that there's high motivation. If if avoidant behavior stays low and voluntary close proximity stays high, we're going to continue to start fading in more instructions. So it might move to one task every 30 seconds, perhaps another couple of tasks every 30 seconds, again, just guidelines. But as you can see, as we move through and progress through the stages, as long as we're seeing approach behaviors continue to maintain and no signs of sort of avoidance, we continue to progress through until we get to stage 9, which actually looks like a very nice, intensive instructional setting. You'll see that stage 9 is also referred to as baseline because in some of the research work, we actually test how are kids going to do in discrete trial to look for their signs of cooperating, signs of avoidant behavior, and those types of things before moving into the protocol. I'm noticing I have just a few minutes left, so I want to show you some data. So we examined the results of progressing through these stages. The first study, we had 4 males. I'll just show you a couple of them. They were between the ages of 3 and 4 years. Referred for intensive intervention focused on skill acquisition, but all did demonstrate some avoidant behaviors here. And what you're going to see here is responding during pre and post session discrete trial sessions. So I'm not showing you the stages of pairing yet. But here you can see the data from the first 2 participants. The left axis shows the rate of problematic behavior or avoidance behavior per minute, and the right axis shows percentage of the session that the participant remained in close proximity or in seat at their therapy table, at the teaching table. The closed circles show in-seat behavior, the open triangles show problematic behavior, and the open squares only for little Matthew on the bottom is his percentage of time spent crying during his sessions, which is a pretty good indicator that we're not doing something he enjoys. You can see in baseline, both boys spent a lot of time in seat during their discrete trial sessions. Both also exhibit some problematic behaviors such as swiping their materials, hitting the therapist, and Matthew also cried during most of his sessions in baseline. Now, the stages of pairing, again, and instructional fading aren't shown here, but you can see if you fast forward to the end, when we get through all of those stages and repeat baseline, both boys showed similar high levels of in-seat behavior, voluntarily, of course, and problem behavior and crying was significantly reduced or eliminated. This is the other 2 participants in this study. Similar results you can see from baseline to post. But I want to jump ahead to our follow-up study because there were a few limitations in that we didn't show clinicians what it looks like during the stages. And so that was problematic. And the participants in this first study also weren't consecutively referred. So it was hard to know, is this going to be what we should expect for every child that goes through pairing and instructional fading, or are there some exceptions? So we continued with a follow-up study that was funded by the Autism Science Foundation. Tom Caribou is the lead author on this. He was my postdoc at the time. And we enrolled all girls in this study. These were all girls diagnosed with autism, again, very young children, and they were all minimally verbal, meaning they exhibited fewer than 5 spoken words. Now, in because of their skill repertoire, we did use some physical prompts to help teach when we presented instructions, but we did not persist with our physical prompts if they were resisted in any way. So if a participant resisted our teaching prompts, we would view that as dissent from the therapy activity. And so we would remove our prompts and simply wait for another opportunity when they indicated, re-indicated interest in interacting with us, and then we would try again. So we had 9 participants. I'll just show you one representative participant. So just like in the 2018 paper, you're looking at just pre and post, okay? So baseline is a discrete trial session. You can see the closed squares show proximity to the therapist. It's okay. It's you know, a little bit under 100%, but is doing all right. We're not seeing a ton of problematic behavior, but we're not really physically guiding or having using any type of escape extinction. But the key feature here are the open triangles, which we call compliance, but this is really just going along with our prompts. So when I give an instruction, I reach over to help the participant do it. The first 2 points, they accepted prompts pretty well. You can see it's close to 100%, but it drops pretty quickly. And what we start to see is a resistance of therapy, essentially resistance of our prompts. And that's going to be problematic if we were to persist in this way. So how did we get to the post where things look really good? What you can see here is this child's responding during stages, the first stages. Now remember, in stage 1, there's no requirement to come over to the teaching setting. And you can see there's also no compliance data path anymore because we're not presenting any instructions. Now in stage 2 and 3, we begin to require close proximity to the therapist. But again, honoring indications that this child may want to get up and go somewhere else and come back at their own volition. And by the time we get to stage 4, you can see that this process has had an impact on their acceptance of our prompts. And we see acceptance of therapy activities at 100% as soon as we get back to stage 4, and we fade beautifully through all stages. So overall, 7 of the 9 participants progressed through pairing with instructional fading. We had high levels of voluntarily staying with the instructor, going along with teaching prompts, physical prompts, and minimal challenging behaviors. And it didn't take that long. All of our participants progressed through in 30 to 80 sessions, which, if you calculate it out, took about 5 to 13 total hours of therapy to complete. We had 2 participants that had different responses. One didn't need the intervention at all. She was doing great in baseline. And one that didn't progress through the way that we typically see. So I would argue that if we can reduce our use of more restrictive procedures to just 1 in 9, that we're doing pretty well. If we can avoid escape extinction and other types of physical guidance. So I'll end here just with a quick close out. I think this photo sums up some of my main points. These are actually my 2 boys, and you can see the older is using physical prompts to turn his frown upside down. And my take-home point really is that there's more than one way to achieve an end result, that the ends don't always justify the means. And we need to think about what our ultimate goals are here. Our science and our understanding of autism is evolving. And I hope that you'll find pairing and instructional fading offer potentially some better ways to promote agreement and assent to ABA therapy. Thank you very much. Here is my email address if you have any questions for me at a later date.
Wow, outstanding, Dr. Ellis. Thank you so much for that presentation. Once again, lots of accolades coming in. I'll let Dr. Jen get her stuff set up while we just talk about, especially that last data set is super powerful. And you may want to take a look at the chat, Dr. Ellis, because there were lots of comments throughout, but also people, I think, are interested in your publications. So if you have links to those pubs, or if any of them are open access or anything, there were a lot of questions, you know, can we have the readings and all those things?
Yeah,
so
I'd be happy to share all of them,
Awesome.
make them
Cool.
available. Thank you.
Awesome. Thank you so much. Dr. Jennifer, are you ready?
I am.
All right, and I will mute and turn off my video. Wait just to see your slides.
Yeah, if you could just see. Can you see my video or can you just hear me?
I could just hear you, but it's all right. More important, we need to see your slides, which we can't see right now. We see the full screen right now, and then
How's that?
just a second to see. That's perfect. Go ahead, Dr. Jen. I'd say let's not worry about the video and just go ahead. We can hear you just fine.
Okay, all right, great. So I'd just like to echo everyone else's thanks to the Emirates College for Advanced Education for giving us this great opportunity to contribute in some way to this very important grant and to participate in this session today. I'm going to be talking to you about trauma-informed care, which is a big topic to talk about in just a few minutes. But I'm hoping to give you all a sense of what trauma-informed care means, and importantly, how it's related to some of the other concepts that we've been talking about today. So before we launch into talking about trauma-informed care, it might be helpful to begin with defining trauma. Most definitions of trauma share some key themes, including the experience of an adverse event, which has lasting effects on behavior. So here's the Substance Abuse and Mental Health Services Administration definition, that trauma results from an event, series of events, or set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening. And it goes on to say that these types of events have lasting adverse effects on the individual's functioning. So this part of the definition is really important for us as behavior analysts because it tells us that trauma, although often conceptualized as an internal event, has effects that tend to be both observable and measurable. We also see this in the Centers for Disease Control's definition. Traumatic events are scary or dangerous experiences that can affect people emotionally or physically. And the definition goes on to say that trauma is a physical, cognitive, and emotional response caused by a traumatic event. Now, I'd like to provide some additional information regarding the prevalence of events that could be experienced as traumatic. So in the United States, the Centers for Disease Control and Prevention estimated that 60% of the adult population has experienced at least one adverse childhood experience, or what we call an ACE. Now, ACEs might include different types of abuse or neglect, but they also might include experiences such as parental mental health issues, suicide or attempted suicide, or witnessing domestic abuse. And the CDC estimates that about 17% of adults have 4 or more of such of these experiences. Now, having returned to the United States only a little over a year ago, I lived in the UK for the past 14 years. I thought I'd also share some data from Britain. The UK Office for National Statistics estimated that 20%, 1 in 5, of the adult population had experienced some form of abuse or neglect prior to the age of 16. Now, the CDC and ONS data estimate prevalence of traumatic experiences in the general population. In special populations, such as people with disabilities or those residing in residential care, prevalence estimates tend to be much higher. For example, McDonald et al. Investigated social services reports and substantiated cases of abuse for children with diagnoses of autistic spectrum disorder, intellectual disabilities, or a comorbid diagnosis. And then they compared those data with non-disabled matched controls. And here's what they found. All groups were more likely to experience some form of maltreatment than their non-disabled controls. Children in the ASD and ID and ASD diagnosis alone groups were 2 to 3 times more likely to experience maltreatment of any type, and children in the ASD group were at highest risk for physical abuse. And compared to matched controls, all groups were more likely to have immediate family members as perpetrators. For children in residential care, risks are even more elevated, with some estimates suggesting that these children are 3 times more likely to be abused than children in the general population. And Mazzoni found that 50 to 75% of children in residential care reported being bullied or otherwise victimized by their peers. And these risks don't just apply to children. A report by Valdarian and colleagues showed that adults with developmental disabilities frequently reported forms of abuse, particularly if they lived outside their family homes and residential care. And please note that this report dealt only with abuse. It didn't focus on the other types of potentially traumatizing events that might occur for people in residential care, such as the very act of being removed from one's home into an unfamiliar environment, or a beloved staff member taking another job and being there one day and gone the next. Now, I'd like for us just for a moment to stop and reflect on the statistics that I've just shared, and also to consider the populations that behavior analysts frequently work with. The takeaway message is that many of us are working with individuals at high risk for experiencing traumatic experiences, whether or not those trauma histories are known to us. Before we go any further, it is important to acknowledge that responses to traumatic events can occur across a spectrum, and not everyone who experiences intense adverse events will experience them as trauma. Responses to trauma can vary widely, from positive growth and resilience to, at the extreme end of the spectrum, post-traumatic stress disorder. And it's also important to note that not all trauma responses are debilitating across the long term. People who experience traumatic events that are not occasioned by human intent, such as experiencing a car accident or a natural disaster, are more likely to have transient trauma responses. So, although not everyone responds to potentially traumatic events in the same way, for some individuals, those events will have lasting effects on social and emotional functioning, particularly if those events are the result of maladaptive social interactions, such as physical or emotional abuse or willful neglect. Given the growing acknowledgement of trauma prevalence across general and special populations, the notion of trauma-informed care, or TIC, has come to the forefront of practice, guideline, and policy development across a number of human service fields over the last 2 decades. Now, the field of behavior analysis is slowly starting to catch up. We're beginning to talk more about trauma, and this is evidenced by the growing number of articles, conference presentations, and podcasts over the past few years that are specific to the notion of TIC and behavior analysis. So what is trauma-informed care? Well, we can think about trauma-informed care as referring to the culture and practices of an organization or field with respect to acknowledging trauma prevalence. Its primary goal is to establish safe and empowering environments and avoid events that may exacerbate trauma responses. Now, I want to make a distinction between trauma-informed care and trauma-specific services, which involve therapies to directly address the effects of trauma. These might include such therapies as trauma-focused CBT, ACT, or even therapeutic life story work. And I want to be clear that both of these approaches have a role to play in supporting people who have experienced trauma. It's not an either-or situation. However, given that most current evidence-based therapies for treating trauma require relatively sophisticated understanding of language, trauma-informed care might be particularly important for individuals who are unable to engage with those other therapies. So those individuals who don't have sophisticated language repertoires. So it's possible that a well-informed trauma-informed care approach can bridge the gap to trauma-specific services for some of those individuals. So let me try to illustrate what I mean. So as I mentioned before, trauma-informed care involves those generic strategies aimed at avoiding, at least initially, trauma triggers and promoting safe and empowering environments. And trauma-specific therapy involves strategies to help individuals process and recover from trauma. So it's possible that if we are working with people with known trauma histories and have information about the specifics of their experiences, we can operate in this overlapping area where we can tailor our engagement with TIC commitments to a client's personal circumstances, which could make us more effective in supporting their trauma recovery. Now, as a behavior analyst, I'm not qualified to deliver any trauma-specific therapies like trauma-focused CBT, but I do a lot of work in this overlapping area to improve outcomes for children and adolescents who have experienced a range of potentially traumatizing events. And I'll talk a bit more about how we might better understand trauma histories when I talk about the specifics of TIC commitments. So let's make a start on that now. Some of you may have read this article written by Dittu Rajaraman and I, along with Holly Gover, Tony Camilleri, Dave Donnelly, and Greg Hanley, and that was published early last year. I'm quite proud, not of us as authors, but of our field, that this was the most viewed article on the JAVA website in 2022 with over 21,000 views. Dittu and I did a behavioral observations podcast about the article, which also was the most downloaded JAVA podcast with over 25,000 downloads. So the reason why I'm proud of that is that behavior analysts are expressing a broad interest in this topic, and it's an important one for us to think about. Our aim in writing this article was to mine the TIC literature to identify the most prevalent commitments across TIC frameworks, and then we map those commitments onto the behavior analytic literature and ethical frameworks. So what did we come up with? Well, if you've engaged in the trauma-informed care literature, one thing you might notice is that different organizations or fields identify somewhat different core principles of trauma-informed care. In our paper, we attempted to distill those concepts that tended to appear across frameworks. We also combined some principles that are separated and other frameworks because we thought that might provide a more parsimonious account of the core commitments. For example, we combined safety and trust into one commitment because it was difficult to imagine a therapeutic relationship where it was possible to have one without the other. And then we also combined choice and shared governance as we thought they were two aspects of the same commitment. And I'll explain a little bit more about that in just a few minutes. Okay, so let's look at each commitment and try to define it behaviorally. The first commitment is to acknowledge trauma and its impact. Now, acknowledging trauma means that you're recognizing that anyone who walks through the doors of your clinic or research lab could have traumatic experiences that are affecting their responses to current environmental events. And that response is identified as challenging or problematic. Could be, they aren't necessarily, but they could be related to trauma. Acknowledging trauma also means acknowledging that some trauma histories may not or cannot be known to us. So as someone who works a good deal in social services with people in with children in the foster care system, even for those children, there are huge gaps in their records and things that they have probably experienced that are not known to us. So if we take all of this together, acknowledging trauma means that we engage in PIC commitments for everyone in the same way that a school might use Tier 1 or universal supports in a PBIS model. In other words, everyone's getting the support, whether they need it or not. Even if you haven't experienced trauma, these types of strategies could still benefit you. Acknowledging trauma also means asking about trauma. But my experience in supervising both students and even BCBAs who have individuals on their caseload with trauma histories is that behavior analysts don't always feel comfortable asking about trauma. I think there is very much a notion in behavior analysis that we should be focusing on the current contingencies only. Remote histories may not really be any of our business, or maybe even a concern that you might re-traumatize someone simply by asking about trauma. I would encourage us to acknowledge that knowing about trauma can better equip us to make the right choices for our clients, including perhaps enlisting the help of other professionals. It helps us operate in that overlapping area that I mentioned before. So it's very important to ask about trauma. However, before we go out and start asking people about their trauma histories, we should be trained on how to do that. There are multiple free trauma screening courses that you can take. ACEs Aware is sponsored by the state of California Department of Healthcare Services and was really spearheaded by Nadine Burke-Harris, who some of you may be aware of. She wrote a wonderful book on the effects of trauma called Toxic Childhood Stress. There's also another website from the Child Health and Development Institute in partnership with the National Child Traumatic Stress Network that provides a training called Trauma Screen Time. So these are really good resources for people to get trained on the ways that we may begin screening our clients for trauma. We also need to be very careful that we're using validated instruments for trauma screening rather than just asking on the fly. The Center for Youth Wellness provides great resources for screening, including what's called a de-identified ACE screening tool. These screeners don't require caregivers or clients to reveal specific experiences, but they rather provide an overall ACE score. Which may make them more likely to engage in the screening process, which may allow you to build that safety and trust so that you can do identified screeners later. If you adopt screening in your organization, I'd encourage you to do it for everyone, not just to select particular clients or research participants who appear to be at higher risk. Screening all clients establishes screening as standard practice in much the same way as we do an informed assessment in an FBA. We do that for everyone. And this is going to reduce the stigma of being asked about traumatic experiences. And we should be clear with our clients and research participants that we screen everyone. You haven't been selected for this screening. And once we have this information, we can begin to think about the ways in which we might need to either enlist the help of other professionals or potentially adapt some of our behavior analytic practices. So we've talked about acknowledging that trauma might be part of somebody's history, but what about acknowledging its impact? Acknowledging the impact of trauma means that we're sensitive to how remote histories can impact on current behavior. And it's very true that we often don't know what those histories are. So the takeaway message is maybe we should err on the side of caution. And this means that we need to be responsive to indicators that people are struggling or distressed and ensure that we aren't doing anything that makes their situation worse. I know that sounds terribly obvious, but I can reflect on my own practice as a behavior analyst over the years, and it's shown me that even though I was very well intentioned, sometimes distress can be seen as another problem behavior to reduce, rather than taking that time to stop and understand what the current environmental contingencies might mean to someone when taking into account their more remote histories.
Dr. Jen, just popping in as the chair, let you know there's 5 minutes left.
Thank you. The next TIC commitment is ensuring safety and trust. I think if we think about the behavior analytic literature and clinical practice, we have many strategies for keeping people physically safe. And I think Dr. Fahmie is going to talk a little bit more about those strategies in the next presentation. I would argue that we perhaps have a less well-developed technology for promoting emotional safety, and we might even struggle to operationally define what emotional safety is. So here's at least a starting point for defining emotional safety from a behavioral perspective. We could argue that emotional safety can be defined as a situation with no or minimal EOs for escape and ample safety signals. And what that might mean in practice is that we identify those things that someone finds highly aversive, and we ensure that we don't program those things into the environment until we've taught the person how to successfully behave in the presence of those events. Ensuring emotional safety also might mean that we don't try to eliminate safety behaviors until we've taught functionally equivalent replacements, even if those behaviors are considered inappropriate or challenging. In other words, we don't sacrifice safety and trust for the sake of behavior reduction. Our challenge in establishing emotionally safe environments is to continue looking for meaning even after we've identified the immediate function of behavior. So it might be true that a person's behavior is maintained by escape, but we need to know, why is escape so important to them? What makes a particular feature of the environment so aversive? And how would that person feel if we tried to immediately eliminate the only effective repertoire they developed for feeling safe? So what about trust? Well, trust, very simply, is developed through the experience of safety combined with dense and predictable schedules of positive reinforcement. This means that reinforcing problem behavior over the short term might reap massive future gains when it comes to building trust, because what that might mean to the client is that the behavior analyst understands and is attentive to their needs. The third TIC commitment is promoting choice and shared governance. We do pretty well when it comes to choice. It's long been advocated in behavior analytic practice, and it's probably not surprising that we prefer situations where choices are available. Shared governance is related to choice, but the aim isn't a specific effect on behavior, which is often the rationale for providing choice in particular contexts. In other words, in the behavioral literature, choice is often a means to an end, such as reducing problem behavior. And that's not necessarily a bad thing, but there's also value in providing choice as a basic human right. And that's more the crux of shared governance. And this concept is related to the Therapeutic Alliance that was addressed by Professor Shillingsburg. Shared governance means valuing people's values. And to do that, we have to understand what their values are, because that's really where the true motivation for change lies. And if you don't believe me, then read Skinner's chapter on values and beyond freedom and dignity, because we really need to understand what's meaningful to people and build our interventions around what's meaningful to them. So at its essence, shared governance means giving people a genuine voice and decision about their treatment and care. We can think about it as proactive social validation, where decisions are made with clients at the outset and throughout the behavior analytic process. Sometimes in the field of behavior analysis, social validity is an afterthought, and we really need to be more proactive about those types of things. So the purpose of shared governance in a TIC framework is at least twofold. First, it allows the person to weigh in on the strategies that they think would be most beneficial for them. And the second purpose is to give individuals a stronger voice, which can promote self-advocacy and empowerment. So in essence, shared governance means that we are doing behavior analysis with someone rather than to them. And the fourth and final TIC commitment is skill building, and as behavior analysts, we're the skill building experts. Skill building within a TIC framework means that we're prioritizing skill building over behavior reduction, recognizing that much of the problem behavior we encounter is rooted in skill deficiencies. So when we encounter a problem behavior that's interfering with a person's success, our first question should be, what can this person do differently so that this problem behavior is no longer necessary, rather than what do we need to do to get rid of this problem? And we also need to think about teaching a range of replacement behaviors to promote success. And this might include supporting people to manage their own interventions and actively promoting resiliency to changes in one's environment. So I think that's about all the time that I have. Here's just a reminder of the core trauma-informed care commitments, and I hope that today's presentation might help you see how these commitments could be implemented into your research or clinical practice. If you have any follow-up questions after this whistle-stop tour of trauma-informed care, here's my information. Thanks so much, everyone.
Let me know if you can hear me and see the slides. Okay.
Can hear you, and I see your full screen now. And now I see your presenter view.
Oh. Okay, 1 second.
So meanwhile, if you have questions or anything for Professor Jen, feel free to put those in the chat. And perfect, now we can see your slides full screen. You're good to go, and you have the rest of the time, Dr. Tara.
Okay, thanks again. Today I'm going to present on the safety and validity of analyses of severe problem behavior. And I'd like to start by thanking the sponsors of this event for having me, acknowledging that portions of this work were funded by an Autism Speaks research planning grant, and also acknowledge that my students were really critical in the assistance of accomplishing what I will be presenting. And in this talk, I am going to highlight some of my own work, but actually much more of other people's work. So what I've done is I've compiled a resource packet to share with you, which includes a copy of these slides and a few extra bonus slides that I've had to cut for time, as well as all of the primary resources that I'll be citing, which will be indicated by little subtext numbers. They're going to be given to you as full text in the QR code that you see here that I will present at the end again for a longer period of time so that you can grab them. Most of what I'm going to be sharing today is based on 2 systematic reviews, one that I recently published and one that is in press that hopefully Dr. Sarah can send out to the email listserv as soon as it is published, as well as an ongoing survey that is admittedly preliminary data. Besides my research team, you all will be the first to see this data. So I need to start with aligning the audience's assumptions underlying the analysis of severe behavior, or the behavioral approach to severe behavior. And I list them here. Severe behavior is susceptible to reinforcement by its social and non-social consequences. That potential reinforcers for severe behavior can be found in the everyday environment through interviews and observations. That reinforcers can be verified through a functional analysis, which I'll abbreviate as FA throughout this. And that treatment programs developed based on a functional analysis are more effective than those based on no functional analysis. Really relevant to today's talk on safety is this third one, which is that reinforcers are identified through a functional analysis. And so what that looks like is, which most of you know, a traditional functional analysis based on the work of Awada et al. Is conducted in a multi-element experimental design, and it involves the repeated presentation of one or more test conditions in which presumed reinforcers for severe behavior are delivered following its occurrence, and a control condition in which presumed reinforcers are delivered freely. And these conditions are repeated usually over several sessions. They may be 10 to 15 minutes in the traditional format, and it's in pursuit of differentiated responding, which you see on this graph, and that is higher rates of problem behavior occurring in one or more test conditions compared to the control condition. And so the FA format, or the experimental analysis, is uniquely that you sorry, I just got a note that said there's network connections. Hopefully that's not accurate, but you're uniquely reinforcing severe behavior under tightly controlled conditions. And if it works as it's intended to work, you should see, at least temporarily, an increase in severe behavior. And so, of course, the benefit of this seemingly counter-therapeutic effect is our ability to identify relevant treatment components as well as rule out irrelevant treatment components for the subsequent treatment of severe behavior. And so, of course, that brings to the question, at what cost? Is it safe to reinforce problem behavior in the context of functional analysis? And a study that may address this question most directly, at least with respect to physical safety, and I acknowledge that I'm not talking about psychological safety here, but with respect to physical safety, there was a study in 2015 in which 99 individuals referred for treatment of self-injurious behavior in an inpatient unit. Their data were evaluated both during the functional analysis as well as outside of the functional analysis. So if you think about the temporary increase in severe behavior during the functional analysis, whether or not it's safe, you have to consider the fact that anybody who's undergoing a functional analysis is engaging in chronic levels of severe behavior. And so you really want to consider the comparison between during and outside of the FA. And so what these researchers showed was that the total number of injury reports were actually less during the functional analysis than they were outside of the functional analysis. But when you corrected for the amount of time, which is substantially smaller amount of time in an FA compared to outside of an FA in everyday life, the injury rate, the rate was much higher during the FA. So 8.5 times higher injury rates during the FA. So you may assume, yes, indeed, the question is, there are some risks involved in functional analyses. Well, what do practitioners say about this, the ones who are actually conducting the functional analysis? There was a survey conducted in 2020 in which 664 BCBAs and BCBA-Ds conducting behavioral assessment were asked about whether functional analyses were inherently risky. And interestingly enough, a lot of them were neutral, disagreed, and strongly disagreed. But when they were asked whether they would like a risk assessment tool, almost all of them said yes. So even if they're not acknowledging that there is inherent risk in the FA, most people, it seems, at least based on this report, are wanting a risk assessment tool to conduct an FA. Perhaps more important than what practitioners say is, what do our clients experience? And I will admit that I wish that I had thought about this many more years before I have. And so my thoughts on this are constantly evolving. And one thing that I've been trying to consider is that when our clients experience a functional analysis, again, we need to situate our conceptualization, especially if they can't talk to us about their experience. We have to situate it within what they experience in everyday life, because again, they're engaging in severe behavior both in and outside of the FA. So I've broken this down on the left column in what they may experience during the FA compared to what they may experience in their typical setting in their home or schools. And so one big difference is that during the FA, they are experiencing frequent establishing operation presentations, which are, we might consider like challenging situations or triggers. They're experiencing them frequently during the FA, versus in their typical setting, it might be the case that their caregivers are really trying to avoid those situations. So they may not be experiencing those situations very often. And I've color-coded what I think is probably perceived as most safe for the client on this one. So when you see the green, that means that this is probably perceived as most safe, where there are no triggers in the environment or minimized triggers in the environment. The second is that in the traditional FA, there is an FR1 reinforcer contingency for severe behavior. So every severe behavior is reinforced versus in the typical setting, there's more of an intermittent schedule likely there. And so here I've given the points to the FR1 contingency for a few reasons. One is that we know that an FR1 contingency is not likely to increase the rate of behavior as high as an intermittent reinforcement schedule. The second is that the FR1 contingency is predictable, and back to Dr. Jen's talk, predictability might go hand in hand with trust. And three, it's been suggested that maybe the FR1 contingency feels empowering or is perceived as empowering to our clients because every time they engage in severe behavior, you back off, you provide the reinforcer. And so that might be somewhat of an empowering contingency, actually. The traditional FA has isolation of antecedent and consequent stimuli, whereas in the typical environment, there's several co-occurring stimuli. This is a highly debated area of where I would put the green on this one. I'm going to go ahead and put it on the left side, but I will give some caveats on this in a minute. There's typically one other person besides the patient or client involved in the FA, whereas usually there's multiple people around severe behavior in the typical environment. And then also, the FA is usually conducted in somewhat of a safe space or an austere space, and the typical setting is likely much more chaotic than that. And again, I'm giving the safety points here to the one person in safe space for obvious reasons. But although it looks like there's much more green on the side of the traditional FA than the typical setting, I do want to acknowledge that that first one, you can't underestimate the fact that in the typical environment, people are often attempting to avoid establishing operation presentations. And so that likely is what's driving this difference in rates between severe behavior happening in the functional analysis compared to outside of the functional analysis. And then I'm going to give you those few caveats I said. So although an FR1 reinforcer contingency may be more safe, it won't be if you're providing potent and irrelevant reinforcers for severe behavior in that FR1 contingency and perhaps developing new functions of behavior. Then it would become unsafe. And isolation may be more safe unless isolation of reinforcers increases EOs for other reinforcers that end up leading to undifferentiated FA outcomes requiring lengthier assessment and just delaying treatment more. Perhaps one person in a safe space is more safe unless that person is novel and doesn't have any rapport with the client, and that space is also different and unusual for the client and they don't feel safe there. So that kind of gets a little bit more towards that psychological safety that is even less often considered in functional analysis. So my first take-home point about this topic is that safety is in the design of the FA. It's based on a series of decisions that you're making as you're designing a functional analysis. And in a recent review that my graduate students and I published, we reviewed FA literature over the past 40 years and identified that there's been lots of variations to that traditional format that have been designed to promote safety. And they kind of fall into three categories. The first is conducting a functional analysis by reinforcing the least harmful topography of problem behavior, or sometimes not even problem behavior, but more appropriate responses. Conducting an FA in the shortest amount of time, conducting it with the fewest amount of EO presentations. And so I won't have time to go into the variety of variations that fall into each of these categories, but one thing I wanted to touch on this talk is a second paper that should be coming out soon is, are there compromises to the validity of the assessment when you're trying to modify the assessment to promote these safety features? And there's three different forms of validity. I was ambitious with my objectives in this talk, I apologize, which is why I'm talking so fast, but there were three different types of validity that I wanted to touch on today, and I'm just going to touch on them: concurrent, predictive, and social validity. And these are all things that I think need to be balanced when selecting an FA format. Okay, so the first is concurrent validity, which is the extent to which two FA variations correspond. And usually what this refers to in assessment research is you're comparing a novel test to a gold standard test. And in the work that we've done, in the review we've completed, we've found that there's lots of articles that compare FA modification, and usually it's for safety reasons that it's been modified, with a traditional functional analysis, which is the tried and true assessment methodology that's led to a lot of effective treatment. And there were many measures that we used. Just briefly, these balanced they balance true positive rates, true negative rates with false positive and false negative rates. I'm going to give you the take-home point first. Like I said, I needed to be brief on this one. So The take-home point in what we found was that many design options are available that maximize safety and also retain high validity. So when we're comparing those variations to the traditional functional analysis, they are really giving us some good metrics. And I've summarized the data just using a simple stoplight here. So the variations that I'm going to put in the green category are those that have high to very high correspondence with the traditional FA. In the yellow category, moderate to high, and in the red category, very low to moderate. And this is based on at least one of those metrics falling within the percentages you see on the screen. And again, this is correspondence with the traditional FA. So we had 11 total variations, and the trial-based FA, latency-based FA, auto screener, 5-minute sessions compared to longer sessions, and precursor FAs all fall within the green category. The ones that are bolded in asterisks were in the very high correspondence category. The practical functional analysis, or ISCA, brief FA, and indirect assessment only. This means just doing an interview, foregoing ever presenting an EO to a client during an FBA. Those are all in the yellow category. Again, this is still moderate to high. It just means that there may be some decrements to those outcomes that as compared to the traditional FA. And then in the red category, I just want to touch on what these are: preference or reinforcer analyses only. So that means not doing an FA, but instead asking a patient what they prefer, what social reinforcers they prefer, and inferring function from that. That's shown not to correspond well. Also, instead of doing an FA of problem behavior, doing an FA of appropriate requests, that's shown not to correspond well. And also foregoing the functional analysis and only doing observations, which interestingly is what most people report to do in an FBA. That's shown not to correspond so well. And this is across 345 cases in 59 articles. So there's a lot of data on concurrent validity available, but it's just one of 3 metrics that I think are relevant here when you're making decisions. The second metric is predictive validity. And this, I think a lot of people would argue, myself included, that the correspondence measures only matter to the extent that the FA does predict an effective treatment. That tends to be people's consensus on what we want an FA to do, is to predict a treatment success. And so I'm going to also lead with the take-home point on this one. The predictive power of FA is not fully known. I know this is not a satisfying take-home point, but this is where I hope researchers in the audience are excited to explore more. I know my graduate team, my research team, is exploring a lot in this area, and that is, we don't know how many of these variations affect clinicians' decision-making when it comes to their treatments and how that affects the client's success in treatment. There are some studies on predictive validity, and they're likely to fall in 2 categories. One is that the more brief format, or the safer format, actually improves treatment success. And of course, this would be a win-win, right? You get a safe FA that also improves treatment success. I've highlighted one here in which treatments based on an ISCA compared to a traditional FA are actually more effective than treatments based on a traditional FA. And then there's other, and this is a robust area of research that gives me caution about making all of my assessments brief. This one is really an important point here, is that sometimes brevity might compromise treatment success. So there's, like I said, a series of studies showing that subtypes of self-injury would be obscured if you used a very brief and safe, what someone would consider safe, assessment of no interaction screener. And that's because if you include one additional condition in your screener, which doubles the amount of time in your assessment, you're actually going to get a lot better predictions about what treatment would be successful for automatically reinforced severe behavior. So I think a lot more research is needed here before we can truly say what the predictive validity of a lot of these variations are. And then the third is social validity. So the extent to which stakeholders accept functional analyses. So again, here, some might argue, well, concurrent and predictive validity don't matter if people aren't using functional analyses, which again, data show that a lot of people aren't using functional analyses. So the social validity of them is also extremely important, which is my 4th take-home point right out the gate. Social validity of FA matters, and we know very little about it. And I think that I would like to talk and think about 2 different forms of social validity here. And the first is on the behalf of the people conducting functional analyses, the clinicians. So what do clinicians prefer? What maximizes clinician success at designing effective treatments? And what causes the least harm to clinicians? Because although we often talk about the child's safety in the functional analysis, the therapist is also usually on the receiving end of the problem behavior, and they also need to have a safe environment. And then, of course, the clients. What does the client prefer? What maximizes the client's success? And what causes the least harm to the clients? And the other one, I want to make the point that I think it's not safe to assume either of these without evidence. And right now we don't have a lot of evidence on any of these questions. And I think it's harmful to assume things without having that evidence. And the second thing I want to point out is that sometimes these might be in opposition. So for instance, a clinician may prefer conducting a descriptive assessment only, meaning they never conduct a functional analysis. They only observe the patient in their typical environment, but that might not maximize that clinician's success. And I do worry about when those are in opposition and what we do about that. I don't have the answers. What we have done in my lab is, and this is the preliminary data, we've scoured the literature on functional analysis variations that promote safety, and we've kind of aligned that with the trauma-informed care commitments that Dr. Jen just described. And we identified a lot of different decision-making points in the functional assessment process that may lend to a more trauma-informed care approach. And we put all of them in a survey, and we sent it out to 114 corresponding authors of FA articles published in the last 10 years. And currently there's been 21 respondents. If you're on this list and haven't responded, please do. But we are going to send it to an additional groups of people besides just the corresponding authors, because we have a pretty skewed sample right now of BCBA-D. So this is a lot of doctoral level mentors really that we got responses from. And we first asked them, well, let me just say this. We were curious about trauma-informed functional assessment with respect to children that have or participants of FA that have likely experienced trauma, and also therapists who may have trauma histories that they're bringing to their therapy session or to the implementation of the functional analysis. And so the first question we asked is, how often are you aware that a client you're surveying has a history of trauma? And then how often are you aware that a staff you're supervising has a history of trauma? And it turns out that people are aware sometimes, most of the time, or always, which is good in terms of acknowledging trauma. We then applied, like I said, these care commitments, which I won't review in detail because Dr. Jen just did that for me. Thank you. But we identified over 40 modifications that may enhance FA responsiveness to this framework. And I will give a quick shout out to one study that has explicitly aligned one FA variation that I hadn't mentioned previously because there's not correspondence data on this, but an FA variation that is directly aligned with the trauma-informed care commitments. And it's called the performance-based ISCA. I don't think I have time to review this very interesting graph, but I just want to mention that one of the key features of this is that every decision in this single session functional analysis is made based on the behavior or the performance of the individual, which is what generally makes it aligned with trauma-informed care. So look up number 20 in your packet when you look at the results for more on that. But what I want to highlight are some of the most often endorsed items for which trauma-informed care commitments they've applied to consider clients, and then the least endorsed for that clients, and then the most endorsed and least endorsed for the therapists. So encouraging and inviting caregiver observation of the FA looks like is often happening, which is excellent. Adjusting the design to allow for less extended exposure to FA conditions. This goes back to a lot of the other things I just showed on the stoplight slide, including a termination criteria based on objective measures of safety, including caregiver in the implementation. Remember when I mentioned like having one person may be safe unless that person is novel and has zero rapport with the patient? Well, perhaps having the caregiver implement instead. Considering within session patterns of responding, which the previous slide highlights one application of that. Collaborating with medical and mental health practitioners when conducting a functional analysis, and reinforcing low severity problem behavior. Some of the least often endorsed, and I'm not giving you the middle, so you're gonna have to wait for the publication to see the middle of it, the other items on there, but the least often endorsed, this one is concerning given the spirit of this symposium, but requiring child assent to participate. Only 31% of people said that they have done this during functional analysis. And that might look like allowing an open door policy and allowing a child to walk out of a functional analysis without scoring that as elopement and providing consequences for it. Collecting data on covert responding, like physiological measures, and collecting data on overt emotional responding like crying. And again, you can see the parallels between what we're talking about with Assent, what we're talking about with Rapport, and some of these less frequently endorsed items. So which of the following have you used for staff? Some of the highly endorsed items were encouraging staff to communicate discomfort to direct supervisors, switching out therapists if needed, debriefing with the clinical team following particularly challenging situations, developing a safety plan with the staff, encouraging the staff to engage in self-care practices, providing staff with knowledge of the client's behavior ahead of case assignment. And I want to give credit here to one of the co-authors on this paper, Laura Narducci. She's a social worker by training as well as a BCBA. And she was the first person to make me even stop and think about a therapist who has a trauma history experiencing, let's say, aggression in a functional analysis, and the many, many, many things I could do to be a better supervisor of that therapist. And a lot of this, I will give credit to her for opening my eyes to. Some of the less endorsed items were collecting social validity measures from staff, offering compensated time for staff to engage in wellness, collecting data on staff integrity, and especially noticing when there's abrupt shifts. So staff who's implementing everything perfectly and then things fall apart and they start implementing, imperfectly. Providing an anonymous forum for staff to voice concerns or discomfort. Considering staff preference in the design of the functional analysis. Like I said, we got a lot of options out there. How do we decide one? Designating a peer liaison to communicate staff concerns with those in supervisory positions, collecting data on staff overt emotional responding, or collecting data on covert responding, which nobody has done, but there are some cool tools out there. My other co-author, Emily Sullivan, is using some of them. So my final take-home point from this presentation is that there are lots of design options. FA implementation requires a balance of priorities, and I would encourage you to use all lenses, the concurrent, the predictive, and the social validity. It's not just the two that you see on this scale. Those are 3 lenses. There's additional lenses I haven't had time to cover today, but using them to achieve a balance. And when you do tip the scale, because you have to select something, always remembering to tip the scale to ensure the wellness of the patient as the central focus. I'm going to leave this up for a few minutes just so that you can get that QR code if you'd like copies of these slides. And like I said, some bonus slides I had to cut, as well as the resources available. Thank you.
Thanks for bringing us home, Dr. Tara. That was amazing. My first reaction is, wow, just you and your team are so productive and generous with what you are creating to share with all of us. So please take a moment, if you haven't already, scan that QR code, grab Dr. Tara's contact info, her resources. We are coming up in the top of the hour, so if you are a behavior analyst who is here for continuing education credits, you've made it to the end. Hopefully you've copied down the 2 code words. Dr. Michelle has put 2 links into the chat. One is an evaluation survey. That's for everyone. Really, we want to hear what you thought about today, ideas for the future, but very important for people who are going to earn CEUs. There's a link to get CEUs. It is a Google form. You need to go there, enter your information. We went over this at the beginning, but because we offer free CEUs, we also use a free certificate generating platform. So we may hit our limit. We have a huge audience here today. So if you get an error today, that is because a number of people, probably 60 people, were in line before you. Don't worry, just keep that link, try again tomorrow. If you hit the same problem tomorrow, by the 3rd day, we should be cleared out from the number of people I can see here. So Dr. Michelle will keep putting those links in the chat. They get kind of buried at the end of a session with all of the thank yous to presenters and other comments. I hope the 4 presenters, feel free to turn your cameras back on if you want to hang out. Just amazing feedback here. I have a lot to think about, and we can't thank you enough for coming out to Abu Dhabi, being here with us in person in Abu Dhabi, but then also jumping into our CEU series so you're able to share your expertise globally. We had an audience from all over. We'll look at those data later. Thank you so much, everyone, for being here. We'll keep the session open just a couple more minutes so we can put those links back in. There's all of us there together. Oh, perfect. Dr. Tara also put a link that you could copy paste. So if you weren't able to grab that QR code, feel free to copy paste that. Dr. Michelle, anything for us to do for wrap up? We've hit the top of the hour.
No, you've done everything. Thank you so much, Dr. Sarah.
Perfect. All right, we'll probably 2 more minutes. We'll keep it open. We'll put the links in 1 or 2 more times as the chat calms down, so you can grab those links. You are all set. You've finished. We'd love your feedback, and just thank you so much for being here. Thank you to our speakers. 1 more minute, and we'll close down here. I don't know why. So we run, Dr. Michelle runs a lot of CEU events. We've never really tapped into the reactions before. I'm enjoying those today, the clapping and the hearts and thumbs up. Oh, what is that one? A party? A rabbit? Okay, we're gonna have to. That one, yeah. I can't tell if it's a megaphone or it's like a party in a cone. The bunny running is how Tara felt in her talk. You got through a lot in that time. All right, we're 2 minutes past. We put those links in 1 more time. Thank you so much, everyone. At 30 more seconds, I will close down the session. Bye, everyone.